I give this presentation. I am a headache researcher. I have mostly studied migraine in the lab, although I do see headache patients in the clinic, and I also see patients in a transition clinic where I see adolescents who've been seen in our UCSF Pediatric Brain Center and help them transition over to adult care. I think I feel like most of you guys probably do have migraine, and that's why you're here. I think one of the most frustrating things about treating migraine and seeing migraine patients is not being able to tell them what migraine is. So I think, you know, this applies to many things, but this is an illustration of the story of the blind scientists who are studying, different parts of an elephant, and they come to different conclusions. And so I think this is a great illustration of migraine, both in people who have migraine feeling like they're experiencing one set of migraine symptoms and someone else is experiencing another thing, but they don't necessarily match. And as clinicians, as people who see many patients, it's cool because we can see some of the similarities that different people are experiencing. And so being able to see many patients and trying to put them together helps us get a better sense of the whole migraine disease as the full elephant. But the other part is scientists. So when I'm in the lab studying, I also feel like, oh, I'm only studying the tail part, and I'm coming to these conclusions, and we only understand bits and pieces of migraine. So I think what I'm hoping to do in this talk is to tell you a little bit more about these individual bits. And right now, we don't have a good, clear picture of a complete picture of what migraine is, but I'm going to give you the bits, and hopefully, as we learn more about migraine and with your help, we can put more of these bits together and have a more complete picture. Did I see a question come up on the chat? Okay. All right, and again, one person might have a specific migraine headache syndrome that's very different from someone else's migraine, but some of the common features of migraine are these attacks. They last usually for a couple hours, sometimes days. They tend to be more on one side than the other, not always, and they're associated with these symptoms like nausea, but also really extreme sensitivity to things like light, sounds, strong smells. So anything that's coming from the outside can be very aversive. And then also, like, we think of nausea maybe as an inner sensation of, feeling your stomach grumbling, and that's really unpleasant during a headache. And then we also categorize migraine into two different categories. One, the common migraine without aura, which most people have, and then some people have this visual phenomenon, which was described, people have known about it for a long time, but this guy was a Harvard psychologist. He drew out his aura every 10 minutes and showed that every 10 minutes it kind of expanded and moved across his visual field. And many people have an aura that kind of expands with the same velocity. And this newer paper was someone who had migraine with aura. He drew out his aura for over 1,000 attacks, and the scientists took his drawings and digitized them, and they're able to kind of show where in the brain, in the back of the brain, which is the visual cortex, which generates these images, how the aura progressed over time. And, even in one person, the aura wouldn't always start from the same place. It could start in different parts of the visual cortex. And I think that can also be expanded to migraine symptoms. Like it doesn't always start off with nausea. It can sometimes start off with light sensitivity. Sometimes it starts off with the pain. Sometimes you have a trigger, or sometimes you have a prodromal symptom or something that clues you in that the headache is going to come. Just to summarize that, this is kind of a plot over time of headache and how we think about headache now. We know it's not just head pain, but it can start off with mood changes, cravings, going to the bathroom more frequently, or runny nose, tearing of the eyes, and those can all be symptoms that come on even before the headache starts. And here, oftentimes people have aura that starts before the headache, but aura can also move into the headache as well. And then, of course, during the headache, you experience these symptoms that we've talked about. And even when the headache is gone, you might feel good about the pain going away, but then you're left feeling tired and maybe having some difficulty concentrating for a couple hours or a few days. So migraines can last for a long time and affect people for several hours to several days. And the other thing I wanted to say is that just even though this is, again, reiterating that this is like the typical progression we think about in our mind, every migraine attack is different for one, and every person has different migraine attacks, which is what makes it really difficult to study. But what we do know in the past couple of years, we found out because of the studies that we've really done in patients. So looking at patients' genes, looking at patients' images during headache attacks, really carefully asking people who have migraines, what are their migraines like? And so I think it's just really critical to try to encourage people who have migraines to talk about it more and to participate in research, because that's the way we're going to figure out this disease. So recent studies looking at genetics, so now that we are able to sequence genes very quickly, we can see how genes are related to different connections. Large studies have shown that migraine can be associated with other neurologic diseases like stroke and epilepsy to a mild extent. But what's really interesting is that migraine is more strongly associated with some psychiatric disorders like depression, anxiety, attention deficit hyperactivity disorder, and Tourette syndrome. So not only are people who have migraines more likely to have depression, people who have depression are also more likely to have headaches. So we know that genetics plays a big role in this. So there are many genes that have come out of these studies, and what you think, okay, great, so we know genes are involved, but unfortunately it's not that simple. Oftentimes it's not just one gene that's causing migraine. We think of migraine commonly as caused by a group of many genes, or something we call polygenic. And the migraine genes that have come out of these genetic studies are thought to control neuron function and also some vascular function, so controlling blood flow, the dilation and constriction of blood vessels. And the control of blood vessels actually has been a long hypothesis of what was causing migraine. So these are this older hypothesis thinking that during the headache phase, dilation in arteries inside the brain were what caused headaches, because a lot of the medications we use to treat headaches tended to constrict the blood vessels. And then also people described a lot of their migraines as throbbing and pounding, and doctors thought, well, maybe the pounding is related to your pulse. And that was why they thought the blood vessels to the brain might be important. However, we've done some more careful studies of those premises now, and this is a study trying to prove whether or not the throbbing of the headache matched people's pulses. And you can see in A and B here, two examples. So in red is the heart rate, and then in blue is the patients would kind of indicate with their hand, you know, how the throbbing headache was going at the same time their pulse was being measured. And you can see it doesn't really match. And this is just an average of all the patients in frequency space, showing that the heart rate doesn't really match the throbbing of the pain. So it seems like the dilation, the pulsation of the artery isn't what is causing the throbbing of the pain, because they're not matched in time. And then now, since we also have the capability of imaging the size of blood vessels, we can put patients who have headache in a scanner. This is an MRI scanner, and look at their vessels to see if they're changing during headache. And then they're also given medication, sumatriptan, to treat the headache. And these investigators measured how much the vessels change during migraine and how much they change with medication treatment. And although they did see some changes in the blood vessels in the brain, it was very slight during headache, and the treatment with sumatriptan didn't really affect those changes inside the brain, but may have constricted some of the outer blood vessels in the head, like outside of the skull. So that also kind of put a damper on the hypothesis that bigger blood vessels is what's causing headache. And now we know that not all medications that dilate vessels will trigger a headache, and not all medications that constrict blood vessels will abort headaches. So I think the general feeling in the headache research community is that these vascular changes probably aren't what's causing migraine. So what do we think is causing migraine? Well, now we have these imaging studies where so scientists in this study gave patients who had migraine, they gave them an IV infusion of nitroglycerin, which is a vasodilator. But we know that this substance will induce migraines. It'll activate migraines in patients who have migraines. But it kind of doesn't do it right away. There's a small break in between. And during this time before the headaches started, these investigators put those people in the scanner. And looked at where in the brain there was signs of increased activity. And so these are brain images of patients who have migraine during their premonitory phase, so before they even get headache. When they're having those premonitory symptoms where they're not feeling well, they know a headache is coming on, but they don't actually have pain yet. And what these images show are that there are areas in the brain that are activated even before headache begins. And these areas include the hypothalamus and areas in the brainstem. And specific regions aren't important, but I will talk about the hypothalamus later. And then another kind of great study that was done a couple of years ago is this is from a paper where they took one patient who had migraines and they put her in an MRI scanner every day at the same time every day for an entire month. So they didn't, instead of triggering her migraine, they just let her migraines happen whenever they did. And luckily, she had 3 migraines during this time. So then the scientists were able to look at, okay, what does her brain look like on the day of her migraine? What does her brain look like the day before and the day after? And what they found was that early on, like before the patient even had the migraine, she was already having activations in some of the same regions that were seen in this study, including the hypothalamus and the brainstem. So this is really exciting and suggests that migraines at least are perhaps coming from areas like the hypothalamus and the brainstem, and less likely to be caused by either blood vessels or from things like external pain or from pain within the brain, but from the meninges, but actually from the brain itself. Finally, this study I put in here because they were able to look at a region of the brain that I'll talk a little bit more later, is the trigeminal nucleus caudalis. And the important thing about this study is that these scientists were able to predict when the next attack was in these patients by looking at the activity in this region. So as activity in this region started to ramp up in patients who had migraine, then they knew that a migraine was happening. So just by looking at the brain, you can sort of tell, okay, migraine attack is about to happen. And the region that was predictive is this region here called the trigeminal nucleus caudalis. I know this is a complicated slide, but this region is special because it receives sensory input from the trigeminal nerve that gets pain information from the face, not just the face, but also from vessels around the brain and around the brain and in the skull, and as well as this brainstem area also gets some inputs from the cervical pain fiber, so pain fibers from the neck. And so a lot of migraine patients complain of neck stiffness or neck pain during the migraine, and so this region kind of nicely puts all these pain regions together in one spot in the brain. And this region sends pain transmission signals up into different regions of the brain that contribute to pain propagation, pain generation, pain maintenance, and is also a region that is able to be controlled by the brain, which we call top-down control of pain. So to sort of bring together what I've talked about, we talked about blood vessels that we think probably aren't necessarily causing the pain of migraine, but we do see some changes in the blood vessel, and these blood vessels are connected to the trigeminal nucleus, which receives pain information from the face and head, and then goes to this region that trigeminal nucleus caudalis that I illustrated here. This is just an expanded view. And so the imaging studies really highlight the importance of this brain region in migraines, but this kind of shows you also that this brain region is getting pain signals from outside of the brain, pain signals from the trigeminal nerve that also go to the blood vessels. And this kind of speaks to the fact that even though we don't think this is what's out here and outside of the brain is causing migraine and causing migraine pain, that there still could be contributions from blood vessels and nerves into the migraine circuit, if that makes sense. And I put this line here of the blood-brain barrier because the medications we use to treat migraines, some of them act within the brain and on excited regions that have increased activity during migraine. And some medications seem to work more out here in the periphery and the nerves on the outside or blood vessels that might feed back into the brain. Does that make sense? Do people have any questions about that? Okay, well, and the other part of—
quick question, just per your earlier comments about the potential relationship to depression, anxiety, or ADHD, does this region influence any of those other disorders?
That's a great question. I would say that the trigeminal nucleus caudalis hasn't been looked at very well as a target for any of those clinical features, but some of the regions where the trigeminal nucleus caudalis project to are very important. So regions like the locus ceruleus, the hypothalamus, all those regions, are probably related to depression and ADHD for sure. And there's this circuit, there's a lot of evidence that this circuit is altered in depression. So depression changes how people perceive pain. And so a lot of the top-down pain, because, I like to think of pain as a motivational factor. So for example, an animal, pain is really a teaching signal, right? It teaches you to stay away from heat or things that are gonna damage your body. But there might be some cases where you wanna suppress that pain in order to get a reward. So maybe there's chocolate there and you're willing to get a little burn for chocolate. And it depends on, are you starving? If you're starving, you might be willing to get burned a little bit more. And so these circuits are dynamic and always changing. And so that's where the top-down inhibition of pain becomes really important, because if you're really motivated and you really need to get that food, you want to be able to inhibit pain, your sensation of pain, because you want to be able to get that food that you need, get that water that you need in order to survive. With migraine and with depression, it seems like the pain is amplified and for whatever reason, you're not able to control that pain from the top down anymore as much. So not only do you get more pain, it also changes your motivation to do stuff. And all of this is interconnected. many of these regions are involved in some or all of those processes. And the other point I wanted to, oh, how am I doing on time? Okay, talk about in the schematic are that these neurons have different receptors, and these are the targets that we use for medications, which I know Jennifer will talk about later. And all of these receptors can be found in the trigeminal nucleus caudalis neurons. Many of them are found in the nerves, and some of them are also found in the blood vessels. Okay. Yeah, and that's just some examples of different medications and where they act. I was gonna talk a little bit about CGRP because I think it's an important piece of the elephant or of migraine. It's a neuropeptide. It's found throughout the brain, but also throughout the body. It is a mini protein, and it binds to calcitonin receptor-like receptor. Many years ago, Dr. Goodsby found that CGRP is increased in blood during a migraine attack. And if we give CGRP, if we just inject people with CGRP, that will precipitate a migraine attack itself. So that's enough to cause that. And then people who have chronic migraine all the time, even if they're not having an attack, they still have increased CGRP. Then importantly, CGRP not only rises with headache pain, but treatment of CGRP, this is with rizatriptan or Maxalt, decreases the levels of CGRP. So showing that CGRP is sufficient to cause a migraine attack in some people. So to summarize, I know that it's very complicated, but that's just sort of the state of how things are. That I think a lot of us are trying to study different aspects of migraine, and the challenge is putting it all together and trying to figure out how we can better help patients and treat patients and tell patients what's going on during a headache. But we do know that headache is due to a lot of different genetic factors that interact with the environment. We don't think that blood vessels are playing a causative role in migraine anymore, but we do feel that the brain and the trigeminal nerve pathway are some major regions that are important in migraine. And then finally, sort of CGRP is something that's been very exciting for migraine treatment that I'm sure Jennifer will talk about more. And that going back, CGRP is kind of all over. And so, we could be targeting it here, out in the blood vessels and the nerve, and it could also be, wreaking havoc inside the brain as well. And that's it. So any questions?
Well, thank you very much, Maggie. That was very informative. I learned a lot, so I appreciate it.
Well, great. If y'all are ready, I'll launch into talking a little bit more about how all that informs what medications we choose to treat with. So let me see if I can show you my super cool slides on that. Yep, there they are, okay. And come back soon. Oh. Alrighty, so can folks see that? Yeah. All right. So basically, kind of reiterating some of what Maggie was saying, when we try to figure out, what is going on with migraine, we're really figuring it out based on this mixed population of people that have, maybe any one of 50, 150, depending on who you talk to, different mutations that can happen with migraine. In the upper right-hand corner, GWAS, that stands for a genome-wide association study. That's the fancy name for what she was talking about, where you look at all the DNA for people that have a certain condition, in this case migraine, and compare it to all the DNA in people that have never been diagnosed with it. And then you're looking for like little subtle differences. And this figure comes from a paper where they were saying, hey, there's more than 40 genes that are implicated in migraine. And, she's right. A bunch of those genes have something to do with the vasculature, and a bunch of them have something to do with how excitable neurons are. And so that metal ion homeostasis, neuronal synapse, and ion channels, all three of those things sort of play into how easy it is to get neurons excited and for them to kind of activate each other in the brain. So basically, there are, in other words, some people in whom gene A might be contributing to them, more contributing to them having migraine, and other people in whom it's more gene B. Although it's going to be A, B, C, D, E, F, G, because it's really multiple genes in everybody that kind of play into this. So we'll kind of come back to this concept. So basically, it's not just the genes. To make things even more, mixed up and multifactorial, you've got your genes that you're born with, and then you kind of go through life and encounter stuff in your environment, whether that's stress or inflammation. Inflammation could be from, having a case of meningitis, or inflammation after a traumatic brain injury like a concussion. That stuff in the environment kind of triggers some changes to the genes that happen after you're already born. And then those epigenetic changes can affect how those genes are expressed kind of moving forward in life. So that also makes migraine very individual. So in terms of how we discovered all the medicines that we prescribe, a lot of it was a complete accident in the case of migraine. I'll get on to the CGRP targeted medicines that we discovered on purpose, but at least in the beginning, it was more of a case of, for example, propranolol. There's a little citation there in a paper from 1966 where somebody was studying it for something completely different, which was like chest pain that you get when you're having sort of a buildup towards a heart attack. And they found accidentally that some people's headaches were getting better on this medicine as well. And then, people went and studied it specifically for migraine. In the case of topiramate or Topamax, which some people take for headache prevention, that one was developed as a seizure medicine. And then after they got FDA approval for that, they started looking at other things that might be helped by that medicine, and found that headache was one of them. And of course, Botox, that was something people were doing cosmetically in the face, and for other, stuff like spasms and whatever, and noticed, hey, headaches are getting better as well. And then there was a formal clinical trial conducted on that. And then, so, a few people getting their wrinkles smoothed out turned into this whole big fancy set of injections that we do around the head and neck for prevention of migraine. So there are a few where we actually kind of discovered the medicine on purpose just for migraine. And I should say treatment. It's not just medicines. Devices could fall into this category as well. So one example would be what Maggie was talking about, where folks were kind of looking at what was going on in the brain during migraine. You can't crack people open like a cantaloupe and look at what's going on in there right when it's happening, but you can sample the blood coming out of brain circulation while something's happening. So that's the jugular vein, which kind of drains the brain. And right around the time of a migraine, if you sampled that blood, CGRP was elevated. And so that led to ultimately development of some of these injectable antibody drugs, and now our first oral drug has been released as well, targeted towards the CGRP receptor. And then in the case of devices, this is a picture of the single pulse transcranial magnetic stimulator. And as Maggie was saying, there's this phenomenon called visual aura a lot of people with migraine get. And then we know it starts in this back of the head where the visual cortex is, and then it spreads from there. And we also know that in a lot of people, aura happens and then they feel a headache. So somebody said, well, what if we can disrupt that process and sort of break it up during the aura and, head it off at the pass before the headache pain even starts. And so this device, basically uses a strong magnetic pulse to alter the electrical activity of the neurons in the back of the head there. And I think the part of the thinking in its development was that what I just explained. And so it was like a purposeful development of this device for migraine based on that rationale, right or wrong. And that's, rather than being an accidental discovery, how we came up with that. Hang on, I'm trying to use my little features here. Maggie, I haven't heard of this being called an Arnold device. I've heard it referred to as the Spring TMS. So anyway, let's see here. Yeah, yeah, Maggie's coming up with the same answer on that one. All right, so then, let me close that chat function here. Okay, so then, yeah, how do we kind of go about this, understanding of how migraine treatments work? Well, in the case of stuff like CGRP, where we kind of went through this purposeful discovery process, it's pretty straightforward. We drew that blood from the jugular, we found all that CGRP, we do animal studies like the one pictured here and discover that the relevant material, the CGRP, is coming out of the trigeminal nerves. And that if you cut or lesion the trigeminal nerve, then you change the vascular response, and stuff like that. Okay, great. So that's pretty straightforward. But then what do you do about those medicines we discovered? Oh, sorry, and another side thought here. We also have medicines. Here we go. Yeah, so this is a quote from an article published by the main developer of topiramate, worked for a drug company. And, good scientist and everything, talking mostly about the development of the drug for purposes of controlling seizures. But I thought this was a funny quote from this gentleman's paper. The main objective of discovering and developing new drugs is to help people with diseases and medical disorders who are not yet being treated effectively. Unmet medical need. Do you think that sufferers really care about the means by which the drug was discovered or about a drug's underlying mechanisms? I mean, it's just kind of a nice way of saying that even if we don't really know how these accidentally discovered to be effective therapies like Botox work, they work, so we're going to keep using them. You can kind of establish efficacy through a scientific trial without necessarily establishing the mechanism. And in reality, what's the financial incentive for establishing the mechanism of a drug that's already been approved by the FDA decades before? There isn't one, to put research dollars into that. So as long as we know it's safe and effective, nobody's really going to, spend the financial intellectual capital to drill down on the exact mechanism. So we certainly, in a hand-wavy way, have ideas about. Let me go back to this. We certainly, in a hand-wavy way, have ideas about how those other medicines work. For instance, we know that topiramate was targeted to keep neurons from getting super excitable and passing on that excitement to their neighboring neurons. And so we kind of assume that that is the category of people, with mutations maybe affecting neuronal excitability that are helped by this drug, and that's how it helps. But, has anybody really tried to figure that out for sure? No. And then we also have, all of those genome-wide association studies that found that there's a lot of blood vessel tissue in which those genes are expressed. A lot of them affect things that we know control vasculature. It's not all about the blood vessels in migraine, but maybe there's some kind of abnormal vascular function. And maybe that's why propranolol, which is a blood pressure medicine, helps with headache. Maybe that's why, CGRP, which at least part of its activity has to do with crosstalk between blood vessels and the trigeminal nerve, terminus on the coating of the brain, has its effect. So even if we don't know for sure, we usually have a theory that we can talk about. Okay, and then in terms of deciding whether something actually works. But what I usually explain to my patients is that we're averaging together all those people with all those different, genetic differences into the same pool when we do a big clinical trial. So pictured on the left is one of the clinical trials that was done in adults for one of the CGRP antibodies, galcanezumab. And for a randomized controlled trial, which is, the big kind of scientific trial we do to figure out whether, thumbs up or thumbs down on a medicine being effective, we tell people you're either going to be taking a placebo, which is something without medical effect, like an injection of saline in this case, or you're going to be taking the medication, and you're not going to know which. And we want to do that because even as you'll notice the black line on the top there, the placebo, even with placebo, people do get better over time. Some of that is they would have gotten better anyway with no treatment. Some of it is belief, that a treatment is helpful. And we need to kind of see if, hey, above and beyond that, there's actually some benefit from the drug. And so we take all these people with all these genetic differences and we pool them together, and on average, we find out that, over time, the drug has, a little more benefit than the placebo. And that's kind of, as a scientific community, how we decide that something works. Device, same basic idea. However, there's this concept that...
Can I just ask a question? And is the reason you don't try to look at the specific genome mutations of the sufferer, is that just like way too expensive?
It's getting to be a lot cheaper. It's more that we don't know that this, genetic fingerprint for a person means that they're going to respond to this drug. Science isn't really there yet. I think that that's where we as headache providers would like it to be by the end of our careers. Maggie and I are kind of early career, but maybe it'll be reality before we retire. What do you think? But yeah, I kind of explained it this way to say, hey, we're going to try a few different medicines. We don't know which one's going to be right for you, unfortunately.
Got it. Okay.
But yeah.
May I interrupt a little bit too,
Yeah.
Jennifer?
Yeah.
I have a question for you. I was hoping you're going to talk a little bit more about the medication that is used for youth. I know you mentioned, for example, Botox and other medication like CGRP, targeted medication, the newest ones. I don't think they can be used for children. Am I right?
Yeah, so that's kind of goes back to this concept of drugs, the evidence we have for the drugs, the FDA approval we have for the drugs, and how that applies to treating kids. So there are medicines for which we have very good evidence, and one of those would be propranolol, and we have FDA approval, I believe, to use it in kids. Same thing with topiramate. But there are medicines for which we don't have as good a level of evidence, for example, amitriptyline, and we commonly use that in kids.
Actually, my daughter tried the Topamax and it didn't work.
Right.
And now she's trying nortriptyline.
Yeah. So there are drugs that may or may not be, so there are drugs that we have good evidence for, medium evidence, or poor evidence. There are drugs that we have FDA approval for in some populations. So CGRP would be one of those. And that population happens to be 18 and older. And for most drugs, the pattern of approval has been first you get it approved in adults, and then you go looking at getting it approved in kids.
Yeah, I heard about that. Mm-hmm.
Yeah, so even though CGRP is not yet approved in kids, there are a lot of pediatric providers around the country that'll make a case that, for an older teenager, their body's getting to be similar to an adult's, and it would be reasonable and safe to try it in that particular child. All right, any other questions before I go on? All right, and then as part of the process of looking at all of these new migraine targeted drugs, some people have kind of made the point with that figure on the right there that when you pull together all these different people with different reasons for having migraine, different environments, different genes, and you throw a particular drug at them, that some of them are going to respond really super well to it, and some of them are going to respond not at all. And so this figure kind of talks about, people that have, a partial response, over 25%. And then, there's this small handful over on the right that, respond completely to the drug. Everything's all better. So I think that a lot of people who have been involved with these trials kind of say, well, we don't know ahead of time who's going to be a super responder, but there's a chance you'll be a super responder to this drug type that you've never tried before. So it's worth trying. So I think it gets to the idea that there are a number of different pathways to having migraine, a number of different genetic differences you have that might be contributing to your likelihood of, having an attack or developing the condition. And it's important to know that when we do a study to decide if a medicine works, we're kind of averaging everybody together that has a bunch of those different reasons, a bunch of those different genetic tendencies, and looking at whether a drug helps a majority of them, yes or no, and whether that majority has helped enough that it makes sense to get the drug approved and released to the public. Whereas, if you kind of look inside those numbers, there may be some people that really aren't helped by the drug at all, or that are super duper helped by the drug. So, it's kind of important to know that that's going on behind the scenes. So getting into some more specifics on the drugs, we have different stuff that we're trying to treat with headache. Maggie talked a little bit about different symptoms that we have, with the prodrome and the migraine and the, prostrome. Nausea, for some of my pediatric patients is an even bigger deal than the headache pain itself, right? And the main medicines we have to treat nausea kind of fall into a couple different categories based on the, part of the family of switches on the neurons that are targeted, or what we call the receptors. So Zofran or ondansetron, many of you probably know of that one, kind of its own thing. It's targeting a certain sub-receptor type of the serotonin receptor, and maybe a little dopamine receptor activity as well. Somebody actually did some studies a few years ago trying to see if it would help the headache part of migraine, and it doesn't really, it just helps the nausea part. And then you have this whole other family of medicines, stuff like compazine and Reglan and, all of those which can be very helpful for migraine nausea, but also are thought to have some effect on the headache portion of it as well. And those are fall in a group that we call neuroleptics. They target that dopamine receptor pathway, but they also kind of slop over to target a bunch of other different pathways. And we think that to some extent it may have some side effects that we don't want. So the con is that you might get some side effects. The pro is that maybe you're going to help the headache itself and not just the nausea. There is also kind of a bunch of them that you might not have heard of so much, like Thorazine or olanzapine, stuff like that, which we don't use routinely to treat migraine nausea, but we might use them more to break up a really bad prolonged migraine, or what we call status migrainosus. Right now, with all the COVID stuff going on, we're trying to scratch our heads and look back in the literature and come up with at-home multi-day treatments that make sense to try to keep kids out of the ED right now, because they don't want to have them up there with all the germy folks. So recently published paper was kind of listing, some of these classic oral at-home treatments for status migrainosus and listed those. So then the main thing that people want to treat a lot of the time is pain. And so if we're targeting pain like inside the brain, kind of that neuronal function and the, nucleus caudalis of the trigeminal and, all of these other places kind of inside the brain, you can think about that as being sensitivity to pain and perception of pain. We have medicines that you would think of as analgesic or pain medication, like Tylenol and ibuprofen. unfortunately, opioids, which we never want to use to treat headache, that fall in that category as well. We also have the anti-seizure medicines that probably work on that part of the, on those portions of the migraine pathway. Antidepressants like venlafaxine and amitriptyline also, have evidence and have been used for migraine prevention, target their area. But then we also have devices like the non-invasive vagal nerve stimulator, the TNS or cephaly. All of these are, we think, modulating the central sensitivity to pain. And then hopefully Angelina is joining us at the end to talk about biofeedback. That and cognitive behavioral therapy are kind of a way to reprogram the central sensitivity to pain in the brain as well. And then there's, as neurologists, we have this funny division where we think about pain inside the brain and pain outside the brain as being like the boundary being kind of like the brain itself. So we think of this lining on top of the brain and the blood vessels that sit kind of embedded in that lining as being outside the brain. So the meninges that get inflamed in meningitis, we've got a bunch of blood vessels and the very end terminals of parts of the trigeminal nerve hanging out together. And maybe there's some weirdness with vascular function that we're targeting with the CGRP drugs. And maybe, something that triptans and caffeine are helping by, targeting that. Obviously, as Maggie explained, it's not the whole picture of migraine, and there's definitely no way that, anybody could claim that abnormal vascular dilation causes everybody's migraine. And then Botox and supplements, I don't think that we really exactly know where to put that in that hierarchy, but we know that they work. So in terms of how we try picking a medication to try first, I mentioned that there's like good, medium, and low levels of evidence. In the last American Headache Society treatment guidelines published in 2012, things that had level A evidence, and not all of these are side effect free, appropriate, or desirable in kids. But if they're worth thinking about because they have very good evidence for efficacy. That is the names and doses that have been shown through randomized controlled trials to have good efficacy in migraine prevention, right? But I mentioned a little bit about side effects. There was a nice article published in the New England Journal, I think it was back in 2017, where they looked at amitriptyline, topiramate, and placebo for kids with migraine as prevention. And this was their fun infographic in the New England Journal's website, where they were pointing out that the most frequent side effect for topiramate was like tingling in the fingers and toes, and for amitriptyline was some feeling sick to your stomach. But more commonly, clinically in practice, what I'm thinking is, okay, these are a couple of drugs one reasonably might start in kids with migraine. And if they have a really low body mass index, I'm not going to want to give them topiramate because that reduces your appetite. If they have terrible insomnia, I might want to give them amitriptyline because amitriptyline has a side effect of making you sleepy, so it might help their insomnia. So another thing we think about is side effects. And then we also kind of have to talk to families and patients about whether there are things they just find unacceptable in a treatment. Like, some of my patients are completely needle phobic. Well, giving them one of the, injectable CGRP medicines, obviously going to be not their first choice. And Botox probably really super duper not their first choice. And then some families come to me with really strong beliefs about, like, I never, ever, ever, ever want to try something that's a prescription medication. What do you have for me that's not a prescription medication? Or vice versa. I think that supplements are, not real, treatments. Tell me a prescription medicine I can take. And then I also think about patients' other medical conditions because, for instance, if you have propranolol, in asthma, you can have your condition be worsened by taking propranolol. So we kind of, I wish it were what we were talking about earlier, like knowing somebody's genome and knowing what medicine's most likely to work. But no, in reality, we're kind of thinking about those other things and then, picking what we think is most reasonable to try first. And so to kind of wrap up, how you guys can help, the patient is to kind of, to make best use of your time in the appointment with your provider, kind of have this conversation beforehand about what is the most bothersome symptom. Sometimes it comes out during the visit that, mom thought it was the pain and the kid's like, no, it's actually my dizziness. My dizziness is the most bothersome symptom. And that really changes, the medicine we would choose and how we would judge success, in that patient. And then think about some of those, family or patient preferences for treatment that I talked about, like drug delivery. Is it needle good or bad? Do you feel yes, no, maybe about supplements? And then as you come away from that visit with us, kind of keeping track of how you respond to a treatment. I have a lot of families that come to me because I'm a super subspecialist that they have like the worst migraines. And so they're kind of coming into this thinking nothing works, nothing I try works. And then I try something for them and they think that doesn't work. But if you kind of break it down, maybe it's partially effective. And even that is good for us as providers to know, because maybe it tells us something about like what category of medicines might work. If it's not this one, because it only works somewhat, like you still have headache every day, but it hurts less, do we need to try a different medicine from that same family of medicines, or maybe just a different dose? And then last of all, just being patient, understanding that it might take a couple of tries, but that there is a ton of stuff out there to try. And so I think, in the end, we can all work together and find you the right thing. So that's my spiel. Any other questions for me?
I'm wondering if there's a minimum time for trying medications, 30 days, 60 days, 90 days, excluding the case where they have a severe and negative response.
I think different providers have, it's somewhat personal. I mean, different providers would, kind of put different numbers on that. But yeah, usually I hear something like, 4 to 6 weeks at the target intended dose, and again, trying to be really conscious of whether there's maybe been a partial effect, not just writing it off because it hasn't completely wiped out all the migraines.
I'm also wondering too, when you see the patient, like at what frequency you have another consultation during that period of trying medication.
Yeah, and that depends a lot on what's going on with the larger world. Like this whole COVID thing's changed a lot of people's practice, and the kind of in my population, I'm treating people that have to drive like 5 hours to come see me. So kind of understanding what the family's ability is to come see me again right away, and whether they're available for things like telehealth. Can I do a follow up with them by telehealth? How severe was their situation when they first presented? And then last but not least, if I'm trying to target and figure out a treatment for menstrual migraine, that only happens once a month. So I might put off my first follow-up for a couple months just to kind of let them go through a couple cycles with the plan and see if they're able to get benefit from the plan. Any other?
Oh, maybe I can ask a question back. What are some things that you would like to be addressed in follow-up visits? Like, that might be more reassuring. If there's limited clinic availability, what are some resources that you think might be helpful?
Who are you asking?
Asking everyone. Like, Jennifer and I work at these busy hospital centers where sometimes it's really hard to get patients in to see us. We have a fantastic group of nurses who, they understand headache very well, and they are, part of our team, and they know how we operate. So I think they're able to address a lot of patient questions in between visits. But do you guys like my chart? What do you guys think? Or maybe you hate my chart.
Well, I think what you're getting at is like what are alternative methods of checking in? Is that the basic idea? Like how to monitor your patient during this difficult time?
Yeah, yeah. And I know everyone is different, but it's,
So I have a chiropractic practice, so I see them quite frequently at the beginning. So I'm seeing them 2 and 3 times a week. So that's wonderful. But now I followed the lead of my veterinarian and it just started giving out my cell phone number to patients so that they can text me and let me know. And I think if you're monitoring like a new medication, like if in sequence with other treatments, like an alternative treatment like mine, probably I would go with just like a once a week text check-in. And that just would be so, it's so easy and it's anybody can do it. So I think that that's probably the best for me now these days.
so your patients really like the more frequent checking in, even if it's just like a brief, like, how are you doing?
I think they're used to it. Yes. And they get used to it too.
So I think it sounds like Angelina's with us now. Are we due to switch over to her right about now?
Yeah, I think I appreciate the questions of everybody. I do think for the sake of time, it would be wise to move on to Angelina. So
Okay.
thank you, Jennifer. That was very nice and very helpful. So round of applause for you and round of applause for Maggie. So thank you. And I'll introduce Angelina, pronounced Kaler or Kohler?
Kohler.
Kohler, okay, Angelina Kohler. She's also from Children's Colorado and is an expert in biofeedback. So thank you so much for being here and welcome and take it away. So thank you.
And
Hi, everyone.
Angelina, I'm just going to give you a one-sentence intro because I work with you. We have 4 providers, 2 MDs, 2 NPs. Angelina has been here longer than any of us. She's one of our NPs who basically, like, I don't know, I think of you as establishing our headache program, really. And she also went and got certified in biofeedback. So, I mean, how awesome is it that I can send my patients to somebody who's not just a biofeedback expert, but also a migraine expert. So anyway.
Oh, thank you. Thank you. Hi, everyone. Sorry, my thing had it started at 5:30, so I'm really glad Kelly sent something out to say it started because I panicked, so I apologize for being late. So what I'm going to do is I'm going to go a little bit into biofeedback, and I'm just going to do a very brief PowerPoint presentation just to kind of get you to understand biofeedback and how it interacts with headaches specifically. And then what I'm going to do is we're going to try and do a down and dirty over Zoom biofeedback experience, okay? So it's not going to be perfect. It's not like what you may see in office if you were to come to see a biofeedback provider. But what I want you to get is to understand what this can do as far as a stress reduction technique and really getting you to understand that mind-body connection that I really do believe does exist when you have patients that suffer from chronic pain. Okay, any questions before I get started? No? Okay. All right, so I'm going to share my screen with you and keep your fingers crossed this works. Or I'm not going to share my screen with you. Let's see here. Hold on one second. All right, let me try this again. Oh, golly. Okay. So
It should be if you just click share screen and then it should let you select a window.
there we go. No, I had to get my PowerPoint running, so I apologize. That was me.
Oh, no. Okay, great.
Okay, so I have nothing to disclose, but what I want to talk about with this is just what the autonomic nervous system is, because that is, you really do have to get families to understand that you're trying to balance this nervous system, and this is the nervous system that you're really trying to work with when you're trying to interact with biofeedback. I want you to understand why we use biofeedback, some of the things that research has shown us that doing biofeedback does do for families and patients, particularly with migraines. Two of the apps I want you to look at, but there's many out there. So I want you to know that apps are really the way that you can reinforce and train and help patients with this, even if they don't have access to a biofeedback provider. And then understanding that what's really beautiful about biofeedback in particular is that particularly in adolescent patients or younger children, they can use this at school. So even when they have stress or they feel a headache coming on, they have a non-pharmacological tool that they can use at school that many of them report can be quite helpful. So this is just a very down and dirty kind of slide of all of the parts of the body. And I always say that you can control everything from the throat to kind of like below your belly button. And that's what the autonomic nervous system kind of manages. So you look at, like, it can help with, it does with dilation of pupils, it deals with body secretions, it deals with heart rate and respiration rate and smooth muscle contraction and digestion. And so what's interesting is when you get families to understand that there's so much that the autonomic nervous system can manage and that you have the ability to control it much more than you thought, they really kind of open up to like, wow, there's actually something out there that I can do that can maybe help me feel better. And that's a really powerful tool for patients that I've found. What you find with the autonomic functions, and these are just the ones that I basically talk to with families so they can start to understand that we're really trying to control a bunch of different things within the body, is blood pressure, heart rate and breathing rates. And I particularly work with heart rate variability training. And so this is the piece that I really work with families. I do a series of 5 sessions, and we really get them to understand that by simply controlling the pace and the rate of your breath, you can actually change your blood pressure, you can change your heart rate. You actually, once you calm the nervous system down, the blood vessels dilate so you can warm the body temperature. You calm the nervous system down, you have improved digestion, you have improved metabolism. Believe it or not, interestingly enough, a lot of patients who I also specialize in dysautonomia, a lot of them have a lot of puffiness and swelling and things like that, particularly in lower extremities. And one of the things they find is that even by doing biofeedback, they'll report that like that swelling and that distribution of like fluids in the feet tends to get better. It has a lot to do with production of fluids, urination and defecation. So the benefits of biofeedback, and I know this is a busy slide, but it really does show you that there's essentially 5 things that you can think about when you're doing biofeedback for headaches. So it decreases the severity of symptoms by 1 standard deviation. And this is actually really powerful. So if you have a child that's walking around a 7 out of 10 constant, if you're getting them down by 1 standard deviation, you go from not being able to be managed, needing medication, to actually getting them to a point where this is functional. They can be functional with these levels. And they may still need medications and they still may spike, but many of them report that they actually are able to go down to a much more functional level when they continually do biofeedback. Interestingly enough, when you stop taking meds, what happens? The headaches come back. You stop doing Botox, the headaches come back. So even 1 year after they do all of their sessions with me or they start learning biofeedback, the treatment remains stable even 1 year after follow-up. The frequency of duration of migraine attacks are actually reduced significantly more based on meta-analysis of 55 studies than taking a preventative medication. Now, as a headache specialist, I do not tell patients to stop taking meds and just do biofeedback. But I find that as an adjunct therapy, they actually find that they can take lower doses, there's less side effects, and they're also not needing to take their acute or abortive treatments as frequently because they're actually having better control of the frequency and duration of their headaches. It reduces the symptoms of depression and anxiety, and as I'm sure has been mentioned, and many of you know, there is a strong comorbidity between mood disorders and chronic migraine. And so giving patients something that not only helps with headache, but helps with mood and depression and anxiety can also be a very powerful symptom or a treatment for them. And lastly, and in my humble opinion, the most important part of biofeedback is it creates a sense of self-efficacy. When you talk to patients, one of the things that they talk about time again is this sense of hopelessness, particularly with chronic migraineurs, is that nothing's worked. Is my medication going to work this time? How bad is my headache going to be? How long is this going to last? Or am I going to have side effects from the medication? I hate to take the triptans. this gives them something where, yes, you may have to take your medication, but by doing the biofeedback, we find that this actually does feel like you have a tool that you can use to decrease the severity of your headache, the duration of your headache, and how frequently it happens. So the two apps that I would like you, I really just want you to download Breathe to Relax, if you can do that. This is an app that is from NIH, and they've done a really good job, because what happens with biofeedback is everybody's like, well, I breathe, I practice breathing, I do slow breathing, I get nervous, I take deep breaths. And you have to get them to understand that it actually is a paced controlled breathing. And what this paced breathing app does is it actually has you breathe in, pause, breathe out, pause. And what you're learning to do with paced breathing, and this is really what the core of biofeedback is in heart rate variability, is you're learning to extend and slow down the breath. But you have to do it so that you don't hyperventilate. And so if you hyperventilate, you're going to get lightheaded and dizzy, and it's going to feel awful. And you're like, why is she making me do this? I hate it. So what you learn with paced breathing apps, particularly something like Breathe to Relax, which is very straightforward and very easy, is you realize that it's all about the pauses. And so you breathe in till you're comfortably full, you pause. You breathe in till you exhale till you're comfortably empty, and pause. And that's it. But if you breathe in too much and hold it and then breathe out all your air and you keep doing that, you hyperventilate. And that's actually the opposite of what you want to do. When you start breathing in a paced manner, it's going to feel very weird, because we don't do that. Furthermore, one of the things that I've started to learn with doing biofeedback with patients is I often get a baseline. And what I find with the baseline is most of our patients that have chronic pain or chronic migraines, they're actually hyperventilating. They're just walking around, breathing thoracically, breathing 22 to 23 breaths per minute. And the optimal breath per minute that I'm trying to get everyone at is at 6. Now, 6, from 22 to 6 seems like a big jump, but actually when you're in deep sleep, you actually breathe anywhere from 5 to 6 breaths per minute. So hopefully we're gonna keep our fingers crossed. I'm gonna get this video to play. But the biggest part about biofeedback is, 1, you don't hyperventilate. 2, you have to have paced breathing. And 3, you have to do abdominal breathing. And we all think that we know how to abdominally breathe, but to do abdominal breathing for a 10-minute period of time is actually kind of tiring. So what I often do is I'm going to show you a very quick video. It's kind of little kitty, but she does an amazing job of kind of explaining to you really what we're trying to do with abdominal breathing. Keep your fingers crossed. If it doesn't work, I'll talk you through it, but we're going to see if I can get it to work. Ooh. YouTube. Are you guys seeing this?
When I first saw this product, I thought it looked kind of crazy. Didn't really understand what the benefits would be, but
No.
I had seen some before and after pictures on the website and thought to myself, you know what, I'm 48 years
We can
old.
hear it, but we can't
Take a
see
deep
it.
breath. If you feel like you're going up and getting a little bit taller, you're breathing so low.
So just listen to the video.
Breathing wrong is when you use your neck and shoulders to pick up your thoracic cavity. So do this now. Take a deep breath and watch. If you feel like you're going up and getting a little bit taller, and then you come down and settle down on your exhale, that's actually a dysfunctional breath. At 5 and under, I found that most kids breathe perfectly. So a number of things happen so that when you ask a 10-year-old to breathe, they start breathing with that upper body breath. It's actually anatomically incongruous and leads to us being in fight and flight, more anxious, having neck and shoulder pain, not being able to sleep, and having digestive problems. So how did we get there? Number 1 is that child starts sitting a lot. They start going to school. We sit way too much, 13 to 16 hours a day. Number 2 is injuries. If you're a little kid and all of a sudden you start skateboarding or skiing, anything that hurts the middle of your body, you immediately stop inhaling and expanding because it hurts. And your breath goes all the way up here to be an upper body or a vertical breath. You start wearing waistbands, bra straps, compression garments. You start sucking in your gut, and all of a sudden that breath that was perfect before you were 5 turns into a dysfunctional one as an adult, and it stays there until you fix it right now. A good breath, a breath that's anatomically congruous, it goes with the rest of your body, is that you inhale and you expand your body. Neck and shoulders don't move. You expand all the way around, 360 degrees. You come forwards a little bit, your sides open up, and even your back opens up. And if you want to see what this looks like, look at your dog, your cat, your fish, any animal on the planet except for us, and you'll see them breathe perfectly, 360 degrees all the way around, expanding on the inhale and contracting, wringing out, getting narrower on the exhale. No neck and shoulder movement.
So I know you couldn't see what she was doing, so you can check this video out, but you get to hear what she was saying. A lot of times we think that we breathe up like this, and so everyone's like, take a deep breath, and you go like this. And what you want to do is you want to feel your hands expand out. And what you want to do is when you see people, when you see animals breathing, when you see young children breathing, you'll watch them, and it's amazing. They breathe out and in. They don't breathe up and down. And that's the biggest thing that you get children to understand, is that it's actually in the stomach and not in the thoracic. When you breathe thoracically, you're actually stimulating the sympathetic part of the nervous system, and that just reinforces hyperventilation. And that also reinforces misalignment of the autonomic nervous system, because the sympathetic drive is just on, and we can't seem to get the parasympathetic branch on. So when you actually breathe abdominally, you are stimulating the vagus nerve, so that you actually do start to calm the nervous system down, so that you can actually start to control that part of the nervous system that, like I said before, that goes from below the chin all the way below the belly button. Okay, so if everyone's ready, I'd like to try a biofeedback exercise right now. Is everybody okay? Good, thumbs up? Okay, so take your Breathe to Relax app and turn it on. And what I'd like you to do is I'd like you to go to settings. And when you get to settings, you can, at the very top up here, you might be able to see it, it says you can select your background. And so there's multiple backgrounds you can choose. Pick one, doesn't matter, you're gonna be looking at it, so make sure you like it. Then you're gonna go down to the bottom and you're gonna see number of cycles. I'd like you to set that for 12. And then you're going to hit done. Now, if you're working with patients with this app, what I really do is try and get them to practice at 6 breaths per minute. But what I typically do with patients when they come to see me in clinic is I have to get them to understand how they're breathing and how that feels when you're mindfully aware of breathing fast. So I start with 12 breaths per minute. The reason I start with 12 breaths per minute is a lot of times when you're stressed, you're angry, you're worried, you're in pain, you're breathing 12 breaths to 22 breaths per minute. And so when you mindfully get patients to understand how fast they're breathing with this, they actually start to realize this doesn't make me feel very good. So what I'm going to have you do is hit the breathe portion of the app, and I'm going to have you set your settings with me, and then we'll reset it, okay? It's kind of messy, I apologize, but there's really no other easy way to do it. So if you hit the start button, you can shorten your exhales all the way down to 2.5 second inhale. Both of them should be 2.5. And you'll find that that's as low as it goes. So you'll see it's got 2.5. And once you get that, hit pause. And then go back to the main screen. So when you have that, what I'm going to have you do is go through the 12 cycles at 12 breaths per minute. And it's going to feel odd, but what I want you to do is understand that this is what your patients are probably walking around, breathing. And when you get them to be consciously aware of this, they start to realize that they actually have more control over how their body responds to the situation than they realized before. Okay, so if everybody's ready, thumbs up. Everybody good? Thank you. All right, so hit the breathe, and you're gonna hit the start button, and you're gonna follow the pacer up, and you're gonna exhale the pacer down. When the pacer goes up, you breathe in, and when the pacer goes down, you breathe out. Follow this. And what I want you to see is how fast this is. And there's really no way you can breathe abdominally when you're breathing this fast. The only way you can do it is breathing thoracically, which again stimulates the sympathetic drive, which we know also like amplifies pain. Good job. Okay, so that was at 12 breaths per minute. Did anybody feel a little lightheaded, a little dizzy, right? Wasn't comfortable. So then what you're gonna do is you're gonna hit the restart and you're going to lengthen it to 3-second inhale and 3-second exhale. And once you have that, hit pause and go back to the beginning. So 3-second inhale, 3-second exhale. This is going to be 10 breaths per minute. And when you have that, we're going to hit breathe and then hit start. Okay, hit start. So this is actually what patients typically do, or kids will typically do when they're taking a test. They usually are breathing around 10 breaths per minute. This is what they're also doing when they're giving a presentation. So if you notice how fast the inhale and the exhale is, you realize why sometimes kids will actually have a hard time and get really anxious with presentations, because feel this in your body, how fast this feels, how your nervous system is responding to this. Okay, so then what you're going to do is you're going to go back and we're going to set it to 3.75. This is 8 breaths per minute. So if you have a younger patient, like a child that's, I do patients 8 and older. So a lot of times kids who are younger, they can't go to 6 breaths per minute. And so what I'll do is I'll have them start at 8 breaths per minute. And so for this, you set your settings at 3.75 inhale and 3.75 exhale. And what's interesting, many of you, if you do this breath, will actually find that this actually feels comfortable because you probably are walking around breathing at 8 breaths per minute. That's what we normally do when we do this. So go ahead and do your settings and see if you can notice a difference. This one starts to get a little bit more comfortable. You see patients not feel so dizzy or lightheaded. One of the other things you have to be aware of when you're doing this with patients is if you have to make sure you don't cause a headache. So a lot of times really check in with families, particularly if they're doing this app at home. Are they starting to get headaches? Because then you really have to problem solve with them. Are they hyperventilating? So this is the breath per minute where I always say breathe in till you're comfortably full, pause, exhale till you're comfortably empty, and pause. Breathe in, pause, exhale, pause. And what's so important about this is you start to see that there was a paced breathing. And that's what's really different about people just doing breathing apps, is it's that paced breath. Typically when we do this, I always tell families that they need to do it 10 minutes a night, every night. And biofeedback is just like learning to play an instrument or build muscle or learn a new sport. You get out of it what you put into it. So 10 minutes usually at bedtime before they go to sleep. And one of the first things that families will tell me they start to notice is that when they do this before bedtime, it helps with sleep. And it's the first thing that it helps with. It doesn't always help with headaches right away, but it helps with sleep. And many times, as we know, if I can get improvement of sleep, oftentimes I can get some improvement of headaches. So the last one is 6 breaths per minute. So for this, what you're going to do is you're going to set yours at 5 seconds inhale, 5 second exhale. So do this one with me, because this is what you're going to be doing with your patients, and this is what you recommend to try and start to do. So when you're ready, hit breathe and begin. So you breathe in till you're comfortably full, pause. Exhale till you're comfortably empty and pause. One thing you should notice is that this is so much slower and more difficult than what we were doing prior. There really does seem to be a big leap between the 10 and the 6 breaths per minute. But again, this breath per minute is what you do when you sleep in deep sleep. So it's not something that patients can't do. It's not something you can't do. What will often happen, you'll see patients do, is they'll exhale out really fast. So you really have to coach them through breathing in slowly, pause at the top, slow exhale out. Then what I do with patients is, what happens is with the nervous system is that when you breathe in, you stimulate the sympathetic branch of the autonomic nervous system. And when you exhale, you stimulate the parasympathetic branch of the exhale. And the parasympathetic branch of the exhale is the one that you're trying to get activated in work. So a lot of times this sounds really heavy and crazy and very complicated, but you tell patients they already know how to do this, because all of a sudden somebody will say, it's okay, Jane, take a deep breath, it's gonna be fine. And so what do? You take a deep breath and you do a long exhale. So after I have patients work on just the even inhale exhales and understanding different rates and how that makes you feel, and then understanding how the pace breath can change that, then I have them lengthen their exhales. So what I'll do with that is I'll have them do the setup again, and I'll have them do 4 seconds inhales, 6 seconds exhales. So try this with me. So you want to have a 4 second inhale and a 6 second exhale. And then what you do is you go back and you start it again. And patients, what you'll find is when they breathe in, they do fine. And when you do the slower exhale, it really gets them to start slowing down their respiration rate, and they get much better control. Then what you can do with this is, once they start doing this with the app, a lot of times patients, you're like, they just can't seem to get it. It's really hard, they don't understand. So what you can often do is, if they're having a hard time slowing down the exhale, you can have them breathe in so they're comfortably full with the pacer, pause, and then exhale with pursed lips. And then pause. And what this does is this really helps them, one, slow down the exhale, better manage the pace of the breath, and then really get that parasympathetic part of the nervous system to kick in. A typical breath per minute, once somebody has been practicing biofeedback, is anywhere from 4.5 to 6 breaths per minute. And as somebody gets to do biofeedback and does it and really starts to practice this, you'll start to get into what's called the zone. And this is where you just actually just breathe in, breathe out, and you can just tell that your body's starting to relax. And we call it getting in the zone. And I would tell families and patients when they're starting to do biofeedback, don't work too hard. You already work really hard. And what happens is, when you just practice with the 6 breaths per minute, is that you start to find that ease. When you can find that ease, then that's when you start to control and balance that nervous system. One of the things that's been very surprising to me as I've done biofeedback, and I have patients hooked up to monitors, they have blood pressure, respiration rate, temperature, is that I'm very surprised at the state of fatigue their nervous system is in. You can see their heart rates are around 110, 120, and these are healthy young adolescents that really are just dealing with such chronic pain that their nervous system just can't seem to calm down, and it really does take time with this. So again, that's why the pace breathing apps are so important, because they really do help the person start to get control over how to manage and balance the nervous system. The second app that I gave you is one where for some patients, it can be really difficult to do paced breathing. So if they put the phone on their stomach, they'll actually know if they're breathing abdominally, and it'll actually help them with paced breathing as well. So it's just another way to get feedback, because that's all that this is. It's slowing down the breath so that you can calm down the nervous system, and that you don't, but not work too hard while you're doing it. So that was biofeedback. These are the apps that you can use. I strongly encourage you to try it at least for 10 minutes tonight before you go to bed, because what you'll find is that it really does help with sleep, and it really does kind of reset a lot of things that happen throughout the day. And a lot of patients really report that it's really become a really nice ritual that they partake in, because they just find that that's the only thing that can calm them down and help them sleep. Thanks. That was my presentation. Who has questions? Yeah. So it is kind of like breathing exercises for labor, except what you find is that they actually, like, I didn't do this. I'm sorry, I had a C-section, so I didn't have to do breathing exercises. But the thing is that my understanding is that there's also like very fast breathing. And one of the keys that you find is that you really have to slow it down. And it can be very much like Ujjayi breathing when you do at yoga. But one of the it can, but what I've often found is that because I do yoga as well, Ujjayi breathing, there's an effort to it. You're breathing in, you want to sound like the ocean. You're exhaling, you want to sound like the ocean. What I find with biofeedback is, again, you're really getting the patient to understand you don't have to work so hard. It's okay. It really is okay. You already work hard enough. Let's just slow the breath down and have it more controlled. Where yoga, because of it, there's a more focused, pressured manner with which that happens, because you're trying to beat heat. Most breathing with yoga is trying to create the tapas, so that heat that goes with this. And I want the opposite of that. I want you to really calm things down. Any other questions?
Well, thank you so much.
Thank you.
That was wonderful, really wonderful. You have me convinced, so I'm totally going to do it.
Oh.
So thanks.
Thank you. I have to tell you, I've been really surprised at how much biofeedback has helped kids. I mean, I read about it. I was really excited to do it. But now that I've been doing it for 2 years, I've really been amazed at how kids respond to it, and how many of these kids, it really has changed things for them.
Angelina, even pretty young kids, because who's that patient I sent to you? It was like 7, 8?
Yeah, so she's 7. She's 7 years old, yeah. And she's great because, so the app that I had, she's the one that turned me on to the app with the belly. She's a 7-year-old, and what we did is when we do biofeedback in clinic, I get a blanket, and she lays on the blanket in the floor, and she'll do her biofeedback on the floor. And it's amazing because her family has said it's the one thing that has helped with so many things, that like medicine really wasn't working. She had side effects to medicine. And the other thing that's very interesting about biofeedback, particularly with migraineurs, is so many of them have abdominal complaints, especially the younger children. And I found that this also is really helpful for the abdominal complaints that tend to go with that.
Yeah, so cognitively, even kids that are pretty young can, depending on the kid, get a good benefit out of this.
Yeah, and I play games with them, and there's a lot of games. There's a lot of apps you can download that have games. And that's actually how biofeedback was started, was where you were playing games. And so they really seem to enjoy it. Thanks.
Yeah, great. Thanks so much. I really enjoyed all the presentations today. So thank you. And sorry about the time difference.
No, I'm so sorry. I'm so sorry.
No problem at all. So,
oh my gosh.
Again, thank you. And it is a little bit past 7. So for the sake of time and to respect everyone's time, just an announcement. If you are a teen and you suffer from migraine, I will be in the next week or 2 starting support groups. So I'll be reaching out to all of you They'll be virtual to start out, and then if there's enough interest in each area, hopefully we can figure out a way to do them in person as well. But look for those emails if you're interested. So yeah, thanks so much, and thanks to the presenters again. If anyone has any questions or comments or feedback, you can always email me. I emailed you all earlier, so you all have my email. So thanks for a great event, and have a good night, and good luck with, hopefully things are getting back to normal, so good luck with everything.